I'm looking higher.
Yeah. Yes.
Yeah, so I got this on, then just start video.
Yep. I just went ahead and started it, so.
Okay.
What?
So it's just gonna be recording what's on the screen. Okay, that's just not showing. Shouldn't it be like showing me?
There it is.
Oh,
Perfect.
Perfect.
Let me go check the other.
okay. All right, who's up first? All right, who's my first presenter?
If I run out and have to go to the bathroom, y'all just mind y'all.
Okay, so you're starting recording, so just you hit your presentation and then you can start whenever you're ready.
I'm not ready. I did pull it right. Oh no. Y'all ready? Yeah. Perfect. Oh, I don't know why it's going. Hold up. Hold up. I ain't ready. Okay. So I did. You can come in. No, you're good. Take the attention off me a little bit. All right. So I did my topic on COVID-19 and child development. Who all in here's had COVID? Okay, perfect. I mean, that sucks, but I'm sorry. Who in here has had like a child that's had COVID? Okay. I know a lot of us don't have kids, but you know, you never know. So everybody knows like the signs and symptoms of COVID and where it came from and all of that and the short and long term effects. But do you really think about like how it affected our children and their developmental aspects? So there's a lot of studies that have been going on now since we're through COVID, just talking about the mental and physical effects that have affected children from birth to all the way up to like 5th grade. Is everyone in here vaccinated? Okay. They're starting to broaden the age range for the vaccines as well. So my PICO question poses the question, during the height of the COVID-19 pandemic, how were the cognitive and functional milestones affected compared to children prior to the pandemic? And could this be the long-term side effects that affect us because of the pandemic? So right here, you can see my PICO question, how it spells out. And then how this applies to nursing is we're going to start seeing an influx of children with developmental delays due to COVID. There's a lot of articles, like I said, coming out just because COVID is just, we're getting away from it now. And it's been a worldwide effect on children. It has increased the developmental delays, mental health issues are on the rise. And then the effects start early as in utero, but those are really emerging studies that are coming out now. So people who this affects most are going to be lower income families, because you have to think, if you have a child during COVID and you can't get to like the doctor's offices and stuff like that, you don't have a ride, transportation, stuff like that, you're not going to get the appointments and stuff you need to assess your child for like developmental delays or like autism and stuff like that, or if they have some life-threatening condition that you don't know about because you can't take them to the doctor because everything's being shut down. Fortunately, technology has played a big role in COVID, because you have the option to do like Zoom through the doctors, but it's so much better to do face-to-face meetings rather than through the Zoom, because then the doctors can get like more hands-on. They can be assessed by a nurse and a physician who are like able to address the learning disabilities that the child could have. And this has also played a big effect on children being more codependent on their parents and a higher social anxiety, just because the kids have never really seen a lot of people without face masks, and that's more normal to them, which is kind of sad. And then there are 5 ways that COVID affects children: the virus, obviously, missing routine appointments, increasing the stress and anxiety, being socially isolated. They're not allowed to get to experience like hanging out with other kids and stuff, and being able to learn in the environment with like the teachers and stuff. And then this website down here is really beneficial. It talks way more in depth, and it has a lot of resources on if you have a child that you think has some learning delays due to COVID. So I can share that with y'all if y'all would like to see that later. And then, like I was saying earlier, the common themes in all the articles were basically saying that COVID has affected the developmental aspects of children in every way possible. And what I found out was this is still an ongoing research that they're doing, just because we are ending the pandemic. But hopefully with all the data and stuff that's coming in, we can better be prepared for like assessing children and stuff, because it's going to affect our nursing career. And these are my references. And the second one won't show, but I had 2 pages. Any questions? Perfect. Let me go get a fan. Who's next? Oh, Lord.
I'm good.
Y'all out here and stuff was just cracking. Oh, you did great. Didn't work. How do I put it in?
Website animation.
I'm not seeing it. Help.
To the right.
I can't see it.
Slideshow.
Okay, I'm Brooke.
Hey, Brooke.
Hello. I did mine on pain management with needle vaccinations. So the PICO question is, in children receiving needle vaccinations, does distraction result in better pain management? So the population is from birth to 18 years old, and the intervention is distraction. Vaccines are important because they eliminate things like polio. Polio was once America's most feared disease, causing death and paralysis across the country. But today, thanks to vaccinations, there are no reports of polio in the United States. Even with COVID, vaccines have, reduced the symptoms already. So that's why we encourage them so much. Children are expected to receive up to 30 vaccines before they turn 18. But according to the CDC, only 69.7% of children receive the combined 7 vaccine series. When a young child like it has a first initial poor response. It causes fear throughout life, and even at this age may cause resentment, not wanting to get vaccines. So the purpose of the paper is to determine if distraction is an effective form of pain management. Distraction intervention is defined as a cognitive or behavioral strategy to relieve pain, stress, and anxiety by distracting the child from harmless stimulus. In Article 1, let's see, it focused on children from 10 to 18, and it showed that distraction through speech or music therapy benefited this age group the most. These kids wouldn't benefit from showing them a toy while you're giving them the vaccine. It's better to explain to them and have their parent or the doctor talk to them during the vaccination process. Article 2. In the past, neonatal intensive care units disregarded or denied the occurrence of neonatal pain. Neonatal response to painful stimuli were often dismissed as physiological or behavioral reflexes and not related to conscious experience of pain. In 2006, the American Academy of Pediatrics updated their guidelines for neonatal pain. They finally recognized that pain was a thing in babies, and they told other hospitals, hey, y'all need to get these guidelines to monitor pain, to avoid it, and to treat it also. Kangaroo care, facilitated tucking, massage therapy, non-nutritive sucking, sucrose, and other sweeteners were found to be significantly reduce the crying time following needle vaccinations. This is a timeline showing, before 1980, a lot of surgeries and everything to do with infants was done without pain medication. And then in the 1980s, they started recognizing, hey, they're experiencing pain. And then in 2006 is when the guidelines were changed. And now research is still being continued to reduce pain. In Article 3, it focused on how to improve adherence to the vaccines and how to reduce the pain and the traumatic experience the children were experiencing. So the article focused on topical anesthetics, distraction, positioning, and the pH of the vaccine. My study focused on distraction, and this study found that video distraction, music, tactile, blowing distraction like bubbles or something like that, and oral distraction like sucrose, patient positioning were the highest, most effective interventions. The interventions would vary depending on the age of the kid. So for infants, breastfeeding or sucrose would be more beneficial. And then as they get older, toddlers, distraction, maybe having a toy to comfort them. And then as they get older, maybe music or speaking to them. In Article 4, it focused on, what healthcare providers can do to reduce stress and ease the situation. Healthcare providers can talk to the parents before the vaccine and give them ways, parents might not know it's okay to breastfeed their infant while they're getting vaccinated. And just explaining to the kid too, but communication is the main key. Giving the parent ways to just help out their kid before and after the vaccination. And then Article 5, the goal of the article was to educate guardians on how they can prepare and soothe their child during needle vaccinations. Parents are recommended to breastfeed, be honest, and explain vaccination, bring the child's favorite toy, and use distractions, and offer care during the injection. So this is just a couple different pain scales that are used. It's really hard to, determine if the baby's just crying to cry or if it's hungry or whatever. So these are the pain scales that are pretty common now. It's the cries for newborns, for toddlers, NIPS and FLAC, the Wong-Baker face scale for preschoolers, which is, the one with the smiley face all the way down to the frowny face. And then for adults, it's a scale 1 to 10. So distraction was found to be an effective way to manage pain and also reduce stress during the injections. This is my references.
Okay, so my name is Mackenzie, and I am presenting my research about effects of mask usage on infants, children's, and adult social interactions. So ultimately, what this is stating is that there are certain outcomes that have occurred due to the prolonged exposure to masked faces for all of these populations. So my PICO question is, does mask usage impair social interactions among infants, children, and adults? So the population being studied is infants, children, and adults. The intervention are those who were exposed to individuals who wore masks. And the outcome is the potential for impaired social interactions. So a little bit of background. About 3 years ago, it seems like a lifetime ago, but coronavirus started off as a simple sickness in March of 2020 that now has resulted in 6,576,088 deaths worldwide. So it obviously has impacted every population within the world through these aspects, either contracting the virus, recovering from the virus, individuals passing away, and then psychological effects such as the world shutting down and everyone going into quarantine. But the main effect that I want to focus on is that individuals of all ages were affected by the potential impairment of social interactions because of the use of face masks. So we know face masks cover our mouth and our nose, which are needed for inferring emotions. So when these facial features are covered, it's harder for all of these people, infants, children, or adults, to infer what the person is trying to convey with their face. So I compiled 5 articles that researched this in depth. Article 1 was the downsides of face masks. So the purpose was to just explore this and see if there are possible solutions to the downsides of face masks, because they are needed to protect individuals from contracting the virus, but there are also downsides to that. So this took 4,691 articles and compiled them together to prove that there are downsides to face masks. The limitation was that this was the first systematic review, but a strength was that it included people of any gender, age, or in any setting, so the data was very inclusive. Results showed that 22.5% of children found healthcare providers with face masks to be frightening. A trial found that when providers are interacting with patients while wearing a face mask, the patient feels as if they are not able to perceive empathy. And another study found that healthcare workers feel as if they aren't able to interact and develop a relationship with their patients due to face masks. So this is relevant because it expands the type of people who are affected by the use of face masks in the hospital setting. Article 2, Children's Emotion Inferences from Masked Faces, explored how children were able to perceive emotions with a partially covered face, and if they would suffer developmental differences and impaired social interactions because of the masks. So 81 children were shown different facial expressions with a face that was covered, and they were asked to identify the emotion being expressed. And the results showed that 47% of children were more accurate when the faces were uncovered compared to the faces being covered. So it shows that the face masks did impair the way that they inferred emotions, which in turn can impair social interactions. The third article, The Consequences of COVID-19 on Social Interactions, took 96 healthy Italian volunteers, and they were shown positive and negative facial expressions in 2 different settings, using a mask or just a scarf. But it also explored the physical and social distance that these individuals would use with people covered by both of those objects. It was performed in Italy and not the United States, which is a limitation, but it's still prevalent because it was a pandemic and affected everyone worldwide. So the results showed that 76% of the participants in the study were able to accurately perceive the emotions when the face was shown with a scarf or a sanitary mask. And 55% of people would reduce physical distancing when the individual was showing a happy face compared to a negative emotion, which I think we can all agree we would do. And then regarding social distancing, 29% of the population would decrease social distancing if the individual is wearing a mask as compared to a scarf. So this kind of disproves the theory that masks alone, using obstructing the facial features is what impairs social interactions, and explains that even though people are wearing a mask, that this would decrease the amount of space related in between those two people and could improve social interactions. Article 4, masking emotions, face masks compare how we read emotions, took adults aged 18 to 30, children aged 6 to 8, and preschoolers aged 3 to 5 to determine if face masks the limit in an individual's ability to infer emotions. So it took 119 people, and they were asked to identify the emotions that were being shown when the face was covered with a face mask, as previously stated in some of the other articles. And it found that 21% of toddlers, 37% of children, and 41% of adults were not able to accurately infer emotions within a masked face. So in this article, I took that this impacted toddlers and children a lot heavier, and shows this is a time in their life when developmental milestones are being achieved very quickly and social interactions are being taught. And so if social interactions are impaired at this, starting at this early of an age, then their social interactions could be impaired for the rest of their lives. And then Article 5, the individual differences in social intelligence and perception of emotion expression. So this used 259 individuals and did 2 tests. So the first test, the individuals were just shown the eyes of the people and asked to identify the expression being shown. And the other test actually used a mask, and then they were asked to see if they were angry, sad, fearful, surprised, or happy. And the results showed that individuals only had 70% accuracy on inferring the emotions, and 2% were less accurate when inferring happiness as compared to negative emotions. So this is relevant because social interactions will obviously be impaired using masks, because the emotions of people who are expressing happiness will not be interpreted as accurately, and that can create misunderstandings within the conversation. They don't know if they're happy about the topic, upset about the topic, which in turn can impair social interactions. So all of these 5 articles researched different things, had different results, but the common themes among the articles, either regardless if it was disproving or proving my question at hand, they were able to conclude that even though a person's social interaction skills might not be affected by the use of masks, the ability to infer emotions while facial features are covered definitely was more difficult than when the face was uncovered, which has the potential to impair social interactions. And then how does the use of face mask affect nursing practice? So obviously in the public, people aren't using masks as much. It's not required in a lot of places, but within the hospital settings, it's highly recommended or required. So when these people in the population are being hospitalized, they're going to be exposed to healthcare workers wearing masks. And so the potential for social interactions to be impaired comes with this because of the inability to infer emotions. Like in the first article, when they were saying that nurses wouldn't be able to create rapport with their patients because they are not being able to show empathy or aspects like that. So a specific intervention to combat the impairment of social interactions would be to use face shields instead of masks to protect from the virus, but also not obstruct those facial features so you're able to infer emotions and not have impairment of social interactions. And then these are my references. Thanks.
Okay, I'm Mackenzie, the other Mackenzie. And and my presentation is going to be on what is the impact of COVID-19 pandemic on the mental health of children and adolescents. So for my criteria, I followed the PICO criteria. My population is the children and adolescents. The intervention is COVID-19 pandemic, and the outcome is the impact on mental health. So mental health is precious, and it's an asset that needs to be prioritized in the same way that physical health. I think a lot of people try to avoid focusing on mental health because they don't want to think about it. But mental health can be affected in many different ways, including during pandemics and epidemics. So back in 2020, To prevent the spread of the coronavirus, schools shut down all over the world. And while that was to prevent the spread of COVID, it did lead to undesirable outcomes. So my aim is to learn the results of the pandemic on children and adolescents' mental health and help healthcare providers know how to help the children and adolescents adapt and kind of heal from these issues that arose from the pandemic. So for Article 1, I have the association of changes of lifestyle behaviors before and during the COVID-19 pandemic with mental health, a longitudinal study in children and adolescents. So the purpose for the article is to examine the impact on mental health in when you compare physical activity and screen time during the pandemic. The strengths I found for the article is that they were observed under the actual quarantine time when we were in home mandatory quarantine. They also used a large population sample. They investigated multiple mental disorders, and they also considered multiple potential covariates. However, the limitations that I found in this article is that the long-term effects between these two parts are unclear because they only did the study between the time before the COVID-19 and in the early phases of COVID-19. But the results found that prolonged screen time and persistently long screen time had a higher risk of psychological symptoms, and they also had an increase in worsening of psychological conditions. They also found that increasing physical activity bettered psychological conditions. For Article 2, I have the impact of the COVID-19 pandemic and societal infection control measures on children and adolescents' mental health, a scoping review. For this article, they wanted to explore and summarize primary empirical research evidence on how the COVID-19 pandemic and societal infection control measures impacted children and adolescents' mental health. The strengths for this article is that they found that parental mental health problems were related to poor child and adolescent outcomes, strengthening the evidence that social environment is an essential factor in affecting mental health for children and adolescents. The limitations found in this article is that they did not use two independent reviewers to compile evidence, which limited the accuracy and material scope. However, they also found that in some studies, parents reported in the place of children, which can cause a lack of validated outcome measure. But they did find that out of the 59 studies, 44 were cross-sectional, 15 were longitudinal, and they reported that there was a negative impact of the COVID-19 pandemic on children and adolescents' mental health. Article 3, I have the impact of the COVID-19 pandemic on quality of life and mental health in children and adolescents in Germany. The purpose for this is to address the quality of life and mental health in children and adolescents from the COVID-19 pandemic. The strengths found in this article is that they used a strengths and difficulties questionnaire that assesses mental health in 4 problem scales. They looked at emotional symptoms, conduct problems, hyperactivity, and peer problems. They also found the risk for child abuse and neglect that increased during times of health and economic disaster. Limitations for this article is they did not take into account other individual and societal factors that may have influenced differences. Clinical interviewers were not used to assess clinical diagnosis of mental disorders, and the results may be affected by response bias. The results found that 2/3 of children and adolescents between the ages of 11 to 17 stated they felt burdened by the COVID-19 pandemic. And based on the parent proxy report in this article, the prevalence of noticeable mental health problems was 9.9 before the pandemic and increased to 17.8 during the pandemic. For children between the ages of 7 to 10-year-olds, it increased from 7.4 before and 26.8 during. And then for 11 to 13-year-olds, it went from 12.8 to 14.5%. So Article 5, it's the mental health considerations for children and adolescents in the COVID-19 pandemic. The purpose is to learn and understand the effects during COVID on children and adolescents' mental health and provide interventions and resources available to promote mental health and well-being during challenging times. The study also lists the risk of child abuse and neglect and exploitation and intervention for those. The strength for this article, They signify the child and adolescent mental health in relation to the pandemic. They also use research information from after 9/11 that stated that excessive television exposure led to increased incidence of PTSD and other mental health disorders. The limitation found in this article is they didn't use a specific age group when compiling information. The results, however, stated that there was a 4 times increase in the mean PTSD score when you compare quarantine children to non-quarantine children. They also found in another study that 30% of children quarantined fulfilled the criteria for PTSD. Another study reported in a county in China that police report of domestic violence increased to triple during the lockdown in 2020. It went from 47 reports of spring of 2019 to 162 of spring of 2020. Article 5 addresses the mental health issues of children and adolescents in COVID-19 pandemic, a comprehensive approach. The purpose is to address the mental health issues of children and adolescents during the pandemic in India. The strengths I found in this article is that they reviewed the effects of excessive use of smartphones and related gadgets, long screen hours, less physical activity, isolation owing to the pandemic, uncertainties, poor socialization options during the pandemic on the mental health of children and adolescents. The study also did not list a specific age group. The results, however, found that more children and adolescents had mental health issues due to the COVID-19 pandemic. And they reported in the study that around 14% of adolescents and young adults between the ages of 15 to 24 in India relayed feelings of sadness and low interest of activities. They also emphasize increased feelings of depression, self-harm and suicidal attempts, anxiety, behavioral problems, use of multiple substances, excessive gaming, and maladaptive internet use. So what is the impact of the COVID-19 pandemic on the mental health of children and adolescents? So all of these articles list that there was an increased amount of anxiety and depression in children and adolescents when they spend too much time on the screen and not enough physical activity. They also found that due to deteriorating family climate, externalizing behaviors among children and more conflict at the home during the pandemic increased the risk of child abuse and neglect. Mental health problems also increased from 9.9% to 17.8% during the pandemic due to a combination of children feeling burdened, difficulty learning from home, having increased family arguments, and having escalated parent disputes. It was also concluded that there was a 4-time increase in the average post-traumatic stress score when you compare quarantine children to non-quarantine children, and 30% of the quarantine children fulfill the criteria for PTSD. Police report of domestic violence increased 3 times between 2019 to 2020. And studies concluded that there was an increased level of depression, self-harm, suicidal attempts, anxiety behaviors, use of multiple substances, excessive gaming, maladaptive internet use, and other issues because of COVID-19 pandemic. These are my remarks.
Gonna do a presentation?
All we have for the I think that's like the.
There's that big of a gap? Please let me present now. Yeah.
Like it's 15 minutes, like a maximum time. Okay. So under 15 is fine. The only thing I have to do is just keep reading. Where do I go? $11:55 is when we come back. Well, no, I was actually at the. I don't know. I mean.
I think we should skip.
It doesn't. I think it
Oh, yeah. Sorry.
Thank you. Yeah. Honey, you can't beat me.
Yep, and then you can just pull up your presentation.
Let's get in real quick. Whenever they push the room.
The link, yes, it'll pull them up to this.
I didn't even put butter on my phone. Oh, me.
All right, good morning, or I think it's about to be afternoon, so afternoon, everyone. My name is Crystal and I'll be presenting on listeria. So listeria, or also if it's also known as listeriosis, is a common foodborne illness, and it's usually caused by a bacteria called Listeria monocytogenes. So it's a gram-positive bacteria, and it's a well-known foodborne illness, but it's not a common foodborne illness. So that's why I kind of want to talk about it. If you can see the quote down below, I pulled it from a news article where this grandfather's, this man's daughter unfortunately lost her fetus due to listeria, and she didn't realize that she was infected with it. And so if I'm just going to read it real quick. So Hopkins hopes that the tragedy of his daughter's miscarriage and the publicity about the outbreak of illness from listeria will be a wake-up call that the bacteria is not something from a science book in 1942 that's been eradicated. It's still there. So although it may not be something we always hear about, we'll hear about listeria outbreaks, but we don't really think about how severely it'll affect someone. It mainly affects pregnant women, newborns, adults older than 65, and those that are immunocompromised. So, all right. So like any foodborne illness, you're going to get the similar symptoms such as nausea, diarrhea, maybe vomiting. But the issue with listeria is that the symptoms don't really show up until 2 weeks after consuming the contaminated food. So some symptoms may not even appear until 60 days after you've been exposed to listeria. So for some individuals, symptoms may look similar and some symptoms may look a little different. So I'm going to go over for pregnant women, like the symptoms will be flu-like symptoms, muscle aches and fatigue, fever, and it's all going to lead to possibly a miscarriage, stillbirth, premature delivery, or life-threatening infection for the newborn. For newborns, it's a little harder to really recognize their symptoms just because they're newborns, they're going to be really fussy. Symptoms like little interest in feeding, irritability, fever, vomiting, and difficulty breathing are one of the main symptoms for if they're infected with listeria. And that's why you're really not going to recognize like, oh, my baby's just infected. And you're not going to be really sure until you take them to the doctor and they test it out. And for any other individuals like those 65 and older, immunocompromised, they're going to get the same symptoms like flu, muscle aches and fatigue, fever, headache, and on other occasions, they're going to have a stiff neck, confusion, loss of balance, and seizures. So what it could all lead to is like a blood infection, and that's going to lead to sepsis. And other times there can be fluid buildup in the brain, and that's going to lead to like meningitis or encephalitis. And there are some occasions where some people just don't really get any symptoms, so they're not going to really have diarrhea and nausea. Okay. This chart that I pulled up from the CDC, it's really helpful. It really just goes over the risk, those that are at risk of getting listeria and why they should probably be avoiding anything that's like soft cheeses or deli meats, any raw seafood and stuff. And this is another quote that I pulled from another article, and it talks about how neonatal illnesses due to listeriosis is often severe and may be fatal in contrast to maternal illnesses that tends to be mild. So one of the things I might want you guys to focus on is probably like what foods are risky. And you might see like raw sprouts are on there. It's kind of surprising, like, oh, raw foods like vegetables can also be risky for some people. So if you're pregnant or if you're thinking about having a kid, just probably avoid certain foods when you're potentially looking at your grocery shopping list. So here's some epidemiology and stats of listeria. So in a year, around 1,600 people can get listeria and about 260 people have died from it. So it can be pretty fatal if you do get infected and if you're not treated early on enough. And for those that are pregnant, it could result in fetal loss for about 20%, and newborns, it's going to be like 3% cases. Another surprising fact is like Hispanic women that are pregnant, they have a higher chance of getting listeria because of the kinds of cheeses that they consume. So soft cheeses like queso blanco, queso fresco, queso cojitas are soft cheeses that have high moisture content, and it's a really ideal environment for this bacteria to grow in. So that's why if you're pregnant, you should probably be careful about what kinds of foods you consume during that time, because you may not know it's contaminated with listeria at that point. Listeria, it can really spread mainly through food processing facilities. And once there's an outbreak, it's really hard to remove it because you need high heat to kill it. So once an outbreak occurs, it can easily spread anywhere. So if it touches a contaminated object, it can go from equipment to equipment, other surfaces, and onto other food products. And listeria can also spread in the refrigerator. So a thing about listeria is it can really survive in cold environments. So it needs to be at least below 5 degrees Celsius for the bacteria to not really spread anywhere. So the treatment for listeria is usually antibiotics. If it's a very severe case, you're usually going to get ampicillin or penicillin G intravenously. And an alternative for penicillin, because penicillin allergy is pretty common at this point, is trimethoprim. And it's usually resistant to most cephalosporin antibiotics, so you're not going to be treated with anything from that family line. And typically, if you're not like that severely infected, you're just going to usually get fluid as another treatment option because you have a lot of fluid loss. So doctors are going to recommend you drink a lot of liquid and probably any Gatorade or electrolytes. And other times they may not just give you any actual treatment because, like I said, fluid's like the best option at this point. For infants that are less than a month old, they're going to be treated with ampicillin and gentamicin as a combination of drugs. So that's going to be given in combination. It's going to be pretty strong, but that's the best way to treat any infant at that point. And for those that are adults and immunocompromised, they're going to get vancomycin in combination with cetrizone and ampicillin. So the best way to prevent any foodborne illness is obviously practicing food safety and proper hand washing techniques. And that's going to be the case even with listeria. So the best thing you can do is always reheating your food properly until it's like steaming hot, because that's the best way to know like, oh, okay, the bacteria has been killed. Other products you should probably avoid are unpasteurized cheeses, like soft and hard cheeses, cold smoked fish, cold deli meats, or hot dogs, because like I said before, because of their high moisture content, it's such an ideal environment for this bacteria to grow. And you should probably avoid raw sprouts and melons because it has a high acidity rate. So it's another ideal environment. So really, listeria grows well in moist, acidic environments. And vegetables and fruits like raw sprouts and melon have that ideal environment, and it's pretty surprising. So if you do have cravings for a melon, make sure you're really washing it properly, and especially keep track of any outbreaks that are occurring with listeria, if that's the case. And there's another quote I found from an article that explains how bacteria such as salmonella stop dividing at temperatures below 10 degrees Celsius, while listeria can multiply at temperatures well below 5 degrees Celsius. So salmonella is a pretty common foodborne illness that we like hear about all the time, but it doesn't spread unless it's like anything above 10 degrees Celsius in the fridge. So even if your fridge is pretty cold, you want to make sure it's even colder than you think, because listeria can spread pretty quickly because it needs an even colder temperature just to like stop growing, to stop being like bacteriostatic basically. And these are little supports and associations you can reach out to like look further into listeria, such as the CDC, and it actually keeps track of outbreaks. So if you ever feel like, oh, there might be a listeria, or you feel like you may have listeria, you can track the outbreak and see, okay, is my state or is my area that at risk? The Mayo Clinic is a really helpful site because it has more clinical like information about it. And another helpful link I found is Mother to Baby, and this is a really helpful website for mothers and mothers-to-be. It has evidence-based research and research and stuff that can explain like not just listeria, but any other diseases related to things you could get if you're a mother. And so, yeah, that's about it. All right. That's 10 minutes.
All right, so my name is Jacob. A little bit about me. I'm a tech in the ICU at Piedmont, and I've been a tech there for 3 years. And something that kind of prompted me to research this was that in our old unit that we had no windows in the patient rooms, and now that we switched to a new unit in the new main tower, we have windows from pretty much the ceiling all the way down to the floor for our patients. And so I thought that was pretty interesting, and so I decided to do my research on that. So what is ICU delirium? ICU delirium is a change in mental status for the patient to where they become disoriented to themselves, the time, or the situation that they're in. This condition can lead to increased hospital stays and longer intubation times. And factors that contribute to delirium are old age, the illness severity, previous brain injury, or surgeries that they may have done previously or during the hospital stay. And an assessment that nurses use to assess patients for delirium is called the ABCDEF bundle, and that's used to combat delirium. It consists of assessment, prevention, management of pain, awakening and breathing trials, choice of drug for sedation, the delirium assessment, early mobility, and exercise and family engagement. And maybe after more research is done, they can add an S for sunlight exposure. And the typical interventions for delirium are sedation and then restraints, because patients become disoriented and they don't know exactly what they're pulling or doing. And so also it's some interventions are teaching relaxing techniques, reducing stimuli for the patient, and anxiety. So sunlight is associated with the circadian rhythm, which is our internal process of wakening and sleeping. And so sunlight is able to help us regulate that for us, because we typically sleep at night and then we wake up during the day when the sunlight comes up. And so sunlight coming into the patient's room would help orient that patient into their regulatory and regulating all that. And I also believe that windows in patients' rooms is a good way for patients to have a good view of the outside world, and makes them more motivated to want to get back outside, because no one wants to be stuck in a hospital during their stay. And something to also think about is like all the blue lights that are in the hospital rooms, because we're not supposed to be looking at our screens or monitors right before bed because it can really mess up our sleep schedule. And so there are many blue lights, especially in the ICU rooms, that can lessen the quality of sleep that patients get during their stay. So for my PICO question, it is for critically ill patients, does sunlight exposure improve healing and ICU delirium compared to no sunlight? So for Article 1, it's the impact of windows on the outcomes of medical intensive care unit patients. So the purpose is to evaluate the outcomes of ICU patients when admitted to rooms with or without windows. And this particular article looked at a 14-bed ICU where half of the rooms had windows and the other half did not have windows. And so this was a very small sample size, but as you can see from the data that it showed that with windows, the incidence of delirium was decreased, and also the length of stay was reduced by a whole day for patients. So for Article 2, the impact of natural light exposure on delirium burden in adult patients receiving invasive mechanical ventilation in the ICU. The purpose investigated the potential exposure to natural light via windows and is associated with delirium acquired in the ICU while being mechanically ventilated. So this also compared rooms that had windows and that did not have windows. But for these patients that qualified for the study, they were mechanically ventilated for 2 days, two consecutive days. And so as you can see, the incidence of delirium was also reduced, and the number of agitated episodes that patients had was lessened compared to windowless rooms. And also the length of stay for patients was also reduced by a whole day. And Article 3 is an association of natural light exposure and delirium according to the presence or absence of windows in the ICU. So the purpose of this was to better understand the non-pharmacological preventative strategies for ICU delirium by investigating natural light exposure through windows and restoring the circadian rhythm in the ICU. So this one looked at a population of 208 patients, where 67 were in windowless rooms and 83 were in windowed rooms. This was also a 12-bed ICU. Patients in windowed room required 22% less opioid analgesics by interventions by the medical team. So I thought this was very interesting because that was less medications that the nurses had to give to these patients and less side effects from those medications that they had to give. And also the reduced incidence rate of delirium for patients in the window room was significant compared to windowless. In Article 4, there's like clinical outcomes of light therapy in hospitalized patients. So this article looked at a bunch of different studies and combined them all into one to compare them. And so 2 of the 5 studies showed improved mood. 2 studies showed decrease in sundowning and restless behavior for patients. And 2 of 6 studies showed reduced incidence of delirium. And then for this studies that they looked at, there wasn't much effect on the length of stay for these patients. And all 8 of the trials that used naturalistic lighting showed adverse or no significant outcomes for patients. So this one particularly looked at naturalistic light versus light therapy. Light therapy is used for compensation of lack of sunlight exposure that mimics natural light. And then naturalistic light therapy is composed of several lights throughout the room to mimic like as if you're having actual sunlight come in to the room. And Article 5 was natural versus artificial light exposure on delirium and incidence in ARDS patients. So the purpose was the comparison of natural light versus artificial light exposure on delirium. And this looked at 16,000 patients with ARDS in the ICU. 21 different ICUs were investigated from 6 academic medical centers. The ICUs had the same layout, with half the rooms being set up for natural lighting by placing the patient adjacent to a window, and the other half of the rooms were set up for artificial lighting by placing the patients 13 meters away from a window. And it showed a big improvement for delirium in ARDS patients. So the synthesis of the literature was that obviously there's always room for more research when it comes to this type of stuff. 2 of the 5 articles analyzed showed that sunlight exposure improved patients' mood and reduced depressive thoughts. 3 of the articles looked at length of stay and showed reduced numbers for patients in windowed rooms. 2 articles mentioned patients having reduced agitated episodes and less pharmacological interventions for those patients. And then 3 of the articles showed that shared the same limitation of having a small sample size. And then for my conclusion, sunlight exposure definitely showed beneficial effects for patients, just with the length of stay, and then also having reduced agitation and ICU acquired delirium. So majority of patients are at their lowest low during a hospital stay and don't want to be there. So hospitals being able to provide some sort of outside influence for the patients to maintain high motivation during their recovery and to make them want to go back outside and live their normal, healthier lives after their hospital stay. And my references.
You personally see like whenever you were researching this, did you see any difference with like the new hospital rooms versus the old ones?
For my patients, it's hard to say because I only worked like once or twice a week due to nursing school.
Yeah.
But for me personally, I love it so much.
I was gonna say, I feel like if anything, it makes the staff happier.
Yeah, it does. And that's something I wanted to also include, but I think I focus more on the patient side, but
Yeah, but I mean,
for
have a positive effect for patient care if your staff is happier. And
Yep.
I feel personally, so like, I mean, working nights is already difficult
Yep.
and like no access to the outside world. Like I can't even see, I feel very disoriented.
Right.
So I think windows are
yeah,
incorporated.
yes, I think so too. I love it so much than the old unit. But yeah.
So good.
Oh, snap, that's big daddy next.
That was so smooth.
Looks like that.
Please God.
They're back here.
It's gonna be far less entertaining than the title may lead you to believe. All right. So. Cool. My name is Winston. I'm doing a presentation on whether or not snake venom can be used to improve patient outcomes. So I have my PICO question. Populations, adults, intervention, use of snake venom. We're comparing really 2 different classes of drugs, but either using snake venom or not, and then whether that leads to an improved patient outcome. Just show of hands, how many people would say that using snake venom would improve somebody's outcome? Well, obviously because of this presentation, but okay. For those that didn't raise your hands. Okay. For those that didn't raise your hands, how about if I asked if the drugs Aggrastat or Turifaban or Captopril, basically like ACE inhibitors, would they improve patient outcomes?
That sounds better than
Okay, yeah. So that's one of the kind of issues that I ran into while I was researching this topic. Basically, the idea has already been taken and somebody has synthesized these drugs using snake venom. So I mean, really the answer is yes, and they have been FDA approved to do so. So Article 1 was testing the effectiveness of losartan versus captopril. It's a double-blind randomized trial, which is basically as good as you can get. Pretty good sample size. And basically what they found was that there weren't really any differences in the effectiveness of the drugs, but there were some issues as far as compliance with these inhibitors because of the cough that, you know, is kind of well known. Again, we're comparing captopril with nifedipine in its effect as an antihypertensive. This again showed basically the same thing. 9 of 10 patients, the systolic blood pressure went down about 50 points and diastolic about 35 points with the captopril. It also, the antihypertensive effect was associated with an improvement of end organ failure. Nifedipine basically did the same thing. It did it a little bit quicker. And one of the main issues with this trial was a relatively small sample size. So you have basically less than 20 people in this entire trial. So not really effective as far as getting a grand scope of things. This is kind of the same thing. Again, we're looking at eptifinabate, which I cannot say, integralin. It's an antiplatelet drug. This is synthesized in the pygmy rattlesnake. Another double-blind randomized control trial. This one had 140 patients, mean age 63 years old. So, you know, adult patients, pretty small sample size. This showed basically the same kind of thing. Integralin is a little bit more dangerous as far as adverse effects go. But I think you have to look at what we're using it for as far as whether or not it's worth it. This is Article 4, alpha versus the placebo. This is for patients with acute peripheral arterial and graft occlusion. It's another randomized control of adults with occlusions in their lower extremities. This one was interesting because they used physicians and other biostatisticians to actually analyze the data and give their feedback as far as the trial goes. And this one was only 297 patients. Again, this drug is made from the southern copperhead, and we did see a greater efficacy and its ability to restore blood versus the placebo. And then finally, Article 5 is the efficacy of aggrastat in the management of patients with coronary artery syndrome. Another randomized parallel double-blind trial. This basically looked at whether or not heparin or whether aggrastat was going to be as effective as heparin alone. And this one was interesting because it kind of did, I guess, a greater time trial. So it did 4 days, it did another one at 7 days, and then finally 30 days. And in all of those time tables, those time frames, we saw a reduction of MI and other associated diseases there. So as far as synthesizing this literature, I felt like it was a lot of kind of just information, just kind of data being thrown at me. what I found was that some of these drugs were more effective than their counterparts, although they are, there are inherent risks with any drug. And I think kind of the problem is finding the right drug to fit the situation. Yeah. References? Questions?
So all those drugs are made from snake venom and carnival?
Yeah, so they're all synthesized from proteins and snake venom.
That's cool.
Mhm.
No, I didn't know that. Yeah, I didn't know that. That's cool. Good job.
Thank you.
All right. There we go. Can I go ahead and start? Is it okay? Or do I need to wait? Okay, cool. All right, so I did mine on effects on grief related to aid and dying, and I'm Madison, if y'all don't know me. I picked this because I didn't know this was legal.
It was me, I messed it up. Leaving.
I don't know. I feel like I didn't touch the wrong thing. Could be wrong. I just needed to read this.
Thanks for taking one for the team that let it happen.
I guess so. That's okay.
What is happening? I think it's just a screen. Let me just pause this.
I'm supposed to show my PowerPoint or something right there?
No, let's just
Okay.
ignore that.
Okay. Do I minimize it? Is that fine?
You should be able to separate it down there.
Okay.
All right.
Okay, guys, we're back.
Rocking and rolling.
Yeah, I think so. Alrighty, starting over, guys. Okay, so I'm Madison. Most of everyone, we've been together forever, so that doesn't matter. But I did mine on the effects on grief related to aid and dying. And so I'm gonna explain what aid and dying is because I didn't really know what it meant or what the definition of it technically. So according to the American Nurse Association, aid and dying is described as an adult patient with a terminal illness that has the capacity for mental decision making to self-ingest or to self-administer oral or enteral medication when certain criteria are met. And so that's basically saying people just have to be competent, and I'll go over the criteria. They have to be over the age of 18. They have to request it from a doctor and then get checked off by another doctor. And then I think there's one more. They have to have 6 or less months to live. And then I want to explain the difference between euthanasia and aid and dying, because people often, like when I was looking at research, I was getting confused. And so I wanted to take a second and explain these. So aid and dying, like I said, you have to have that certain criteria. And you have to self-ingest the medication, and it has to come directly from a doctor, and you have to pick up the prescription. But euthanasia, that's when someone else besides the terminally ill patient gives them the medication. So the difference is this aid and dying, the person wants to euthanasia, the person didn't technically want to, and someone else chose that for them. Okay, the criteria, like I just said earlier, it's to be eligible for medical aid and dying, you must meet all the 4 of the following. So you have to be over 18, terminally ill with less than 6 months to live, mentally capable, and then able to self-ingest the medication. And then, like I said, you have to request it from a doctor. But a lot of doctors still, because it is such new information, won't allow it technically yet. So they'll send you to a different doctor that they know approves aid and dying. And I'd like to take a second. So a lot of these patients have been on hospice prior and just got tired of being on hospice and tired of living with a terminal illness. Because most of the illnesses were either cancer, Huntington's, ALS, and there's a couple more, but cancer was the main one. And so it's not that these people didn't want to live, they were just tired of living with a terminal illness that was beating them up every day. And so a lot of people will call this physician assisted suicide as well, but that's super offensive. I was doing research that it's really offensive to people who choose this method of dying. And one of my articles even calls it physician assisted death. And I didn't really appreciate that because this isn't what these people wanted. They're not committing suicide. And so one of the articles says that, and I don't love that, but the information was good in the article. Okay, so the introduction, these are all the states that it's legal in the United States, which is crazy because I had no idea about any of this. Oregon was the first one to approve it, I think, 1997. And it's available to 176 million citizens worldwide. And so a lot of other countries, let's see, there's Switzerland, Netherlands, Belgium, Colombia, Canada, Austria, New Zealand, Spain, and Australia that it's all legal in. And it's currently legal in 11 out of our 52 states, but you can see there's literally none in the South. It's all different places. So I thought that was interesting. That's probably why we haven't heard about it. But why does this impact nursing? Why do we care? Why did I choose this? As people are dying and going through that with their families and patients, we are there to comfort them and help them through that hard process. And so as this becomes more legalized, like we go off to different states or it comes down to the South, we need to know how to like help our patients cope. Because if a patient walked in and this was their mode of dying and they chose to do it in the hospital, I wouldn't know how to help with that mode of dying. Like they're planning to die, like they have their death date already. Like that would be really hard for me as a nurse to help with. And so I wanted to figure out the grief they go through and the grief their family goes through. So my purpose statement, my PICO, is in terminally ill patients, what is the influence of aid in dying on the grieving process? And this is just a little bit more information before we get into my articles. This is the people who like picked up the prescription, and this is how many people actually self-ingested it and died from it. So a lot of it, you can see like a third don't ever take the medication. And so I don't really know what they do with it. I mean, I guess they keep it, I don't know. But I thought that was a really interesting stat. And it started in 1997 with Oregon over there. And then this is the medications that the doctors will give them in various forms and various amounts and however they do that. So I thought that was interesting. The different kinds they give: sedatives, analgesics, paralytics, they're all different types of medication. Alrighty. So this is my first article, and it's called Family Members' Experiences of Assisted Dying. I'm not going to try to pronounce the author's name, but I think my latest article is from 2018. And so the research is really new because it's such a new topic. But this one's from 2019. It was a meta-analysis, and it was 19 articles. 11 were 8 were surveys, and then 11 were interviews of the articles they picked. And the criteria, you had to be over 18 and be involved in an assisted death case. And then the purpose, how it relates to my PICO. It reviewed families' experiences and the family's point of view in assisted death cases. All right, my strength, like I mentioned, it's the first meta-analysis. It was the only one I found. So it helps decrease bias because they're not performing the study themselves. They're just looking at it and comparing data. And then the limitations, 4 out of the 19 were in the US. So that means 15 weren't, but there's just not a lot of data yet because it's so new. And there were small qualitative studies. A lot of people still don't want to present in this or participate in the studies because the social stigma behind it, and they're nervous, which I get. I mean, it's really new and it's a different kind of thing. So they're pretty much all the studies are pretty small. And then the results, families were able to cope more effectively. They valued being aware of the deaths. It led to preparedness. This was a quote from a family member in the article. It said it allowed them to keep communication open with the patient until death. And then this was the data that I had from it. Because a lot of them are interviews, there's not as much number data, but there's a lot of quotes from families. And then Article 2, this one was done in the US. So that was helpful. I think 2 or 3 were done in the US in my article. So this one's from 2018. It was in-depth interviews with family and close friends. And these were the 3 questions they asked them is, what is the individual's orientation towards aid in dying? Tell me about patient X, family member, fill in the blanks. And then what kind of person he or she was. Okay, the strengths of this article, it was the first article to focus primarily on the caregiver's experience, which was what I was particularly looking at. And then it gave various descriptions of what the families felt and how prepared they were for the death and what the patient preparedness was. Limitations, once again, small sample size. I think it was 19 caregivers, so that's really hard to generalize to like a whole population of people. And so that was definitely a negative of this article. And then I wish it would have focused greater emphasis on the grieving process. A quote from a family member, which I found interesting, they described the death as like sweet and gentle. Because once they take the medication, whichever medication they take, that will depend how long it takes. But there was a whole paragraph about how the family member appreciated that they weren't suffering anymore and that the death was extremely sweet and gentle, which I've never heard death described like that. So I thought that was interesting. Families were able to prepare the bodies as requested because in a lot of cultures that's extremely important. And so I'm sure that family appreciated being able to prepare the body however their culture likes them to. They appreciated the time spent prior to death. Caregivers suppress anticipatory grief until after death. I found this next one interesting. 0% reported PTSD or related disorders. And then caregivers were more likely to accept the patient's death. So that probably relates to Pico the most, the bottom one. That they were able to accept the death and there wasn't any PTSD related disorders or rarely any grief associated with this article. Article 3, it was a mixed method. So it was multiple mini interviews to discuss signs and symptoms with difficult bereavements, and then the other part was questionnaires. And it explained, it explored grief of families who lost a loved one through aid in dying. This one's really interesting, the title. They compared assisted dying to natural death with palliative care. And so this one and another one was the only one I found that compared two types of death and the grief associated with that. So the strengths, like I just said, it was the first one to compare those two modes of death. And limitations, questionnaires were self-reported. And so that always leads to some errors there. And then this study, the limitation it lacked, it didn't differentiate between men and women, and then it lacked cultural diversity. I did appreciate this because it had results and numbers, which I wanted to see. In the prolonged grief assessment, if you score over 55, that means you qualify for prolonged grief. And aid in dying, they're pretty close, only a couple of decimal points off, but was still associated with less grief. It said most of them could lead to softer grief, and then suggest aid in dying does not increase prolonged grief. And there was little to no difference between the two groups. Article 4, it was a qualitative interview method. It was only one interview, so I think it would have been helpful if it had more, and it was done in Switzerland. And so it might not be applicable to the United States. The interviews were in person though, so that was a positive. It mentioned the influence on society, which I think all of these articles mentioned to some degree of that. And then they described it as an intense process. The process gave insight to loved ones suffering. Individuals did not seek bereavement after, and then they enjoyed filling their loved ones' wishes. And then the social stigma, again, like a couple other articles mentioned. Article 5, this one was done in Oregon, which was the first state to ever legalize this. It was a qualitative study. Granted, there's only 22 interviews with individuals, which I wish I could have seen more, but this article didn't have that. They gave insight into the bereavement and grief of families whose loved ones chose assisted death. My limitations were, this one had one interview as well, and then the limited sample size and the social stigma again. But they were in-depth qualitative studies, so it was a very long interview. It was just one. And then this article broke it into like different areas, but I'm going to focus on the grief and the sense of control. The grief for participants reactions were varied, and the sense of control, they appreciated time for final words, meaningful conversations, and appreciate the time given. And then it led to a greater acceptance. And this one actually was interesting because they felt comfortable sharing the mode of death, unlike the other ones. This is my last article. This compared assisted death to suicide, and this one was last year. And it was a mixed method, and the purpose was to explore grief reaction and social reactions. This one had a chart to it, which I appreciated. It was a small sample size done in the Netherlands. but it was the first to compare aid in dying and suicide. And then the results, aid in dying is associated with less grief, and then you can see the results there from the study. Okay, conclusion, nurses' responsibility, we talked about this in the beginning. Why does it matter to us? We're there to comfort families and the patients through their hardest time, and choosing this death, I'm sure is not easy. And they think about it and they go through a really hard process to get this mode of death accepted for it. And so we're just there to comfort them, and we need to be understanding when people come in if it gets legalized. In Georgia or wherever you go, we need to understand that these people are already at risk for social stigma and not to invite that into the room. And then all of the studies except one found positive effects on grieving associated with aid in dying. And that one that didn't, it was just equal. I think it was a natural death with palliative care. They just found that there was no difference between. And then future recommendations. I would like to see studies with greater amount of people. They're really small studies. And I think if you saw ones with like 100, 200 family members, you would get more of a reference of like what these people are going through and if the grief was less effective. Okay. It's fine. We're at the end. And then, oh, you're fine. And then I would like a higher level of research. I only saw one meta-analysis, and I would like to see a lot more with this research and let them compare different articles. Okay, any questions? No, cool. It's broken. I broke it.
Something's unplugging.
Madison, did it say if any of the states, like in the South, are looking into like legalizing it, or they don't didn't speak of it really?
Yeah.
Yeah,
Is there, oh my God, you let them bring it to like 20 years ago.
yeah.
You can't have nothing there.
It went away again.
No, she just paused it real quick. You look.
It just went away again. Oh, wait, here.
It's loading. It's
Okay,
like
here we go.
50% there.
Perfect.
Passes out.
This is you?
This is me.
All right.
Hey, mama.
All right, whenever you're ready.
All right. Hello, everyone. My name is Rebecca. Just a little background on me. I used to be a tech on the oncology floor, done my practicum on the oncology floor, and now I'm about to be working with Katie on the oncology floor. So my whole presentation is going to be based off of chemo. But my presentation is called Food is Fuel and How Pre-Nutritional Assessments Affect Chemotherapy Outcomes. And my PICO question is, in chemotherapy patients, do pre-nutritional assessments improve outcomes? And so that's taking on the basis that we are looking before they start chemo and doing a really deep in-depth nutritional assessment, making sure they're ready for this very vigorous treatment. And just a couple of things about chemo is that it's really hard on the body. I mean, they've got to kill that cancer. So it'll mess up your electrolytes, red blood cells, platelets, white blood cells. You know, you're susceptible to infection, delayed wound healing. And, you know, in nursing school, we talk about nutrition in every subject and disease process that we ever learn about and how important it is. So, we just want to know that, you know, food is the fuel and it's to keep us going through chemo and so we can have a better outcome. And then this is just my PICO broken down. We're looking at chemotherapy patients and just looking at those nutritional assessments beforehand versus like little to none assessments, and then better clinical outcomes. And so this is my research. So my first article, it is looking at a population of cancer patients that are like 70 years old or older in Australia. And so they want to determine in this article if BMI makes it and can predict like 12-month mortality. So they're looking at BMI, malnutrition risk, and seeing if that will determine if the patient will die within a year or not. And so they use surveys with the patients, they calculated their BMIs, and they use their other screening tools just to see how their nutrition is. And so the results that they found that BMI is not a good measure of malnutrition by itself. So when you're going in the doctor's office and they calculate your BMI and they just tell you you're underweight, normal, overweight, or, obese, but that's not, just looking at that is not looking into like the quality and the quantity of food that they're getting into their body. So just that one measure, it's a good measure, but it's not the best measure for nutrition. And they also found that there was no significant association between 12-month mortality and malnutrition unless they were not receiving chemo. So that's just to show that even if they're not receiving chemo, there's not really an association between the two. So that ruled out from my PICO that BMI alone cannot be used, and it provided a lot of background on my for my essay and everything. But they also found in this article that doing nutritional assessments before and throughout can showed that the patients preserved more muscle mass and they had a better quality of life and enhanced treatment outcomes. My second article is one of my favorites, actually, but they wanted to assess the distribution of malnutrition among all the chemotherapy patients. They looked at 300, but they found that the malnutrition was pretty evident across the US. But my favorite part was that they studied the physician's diagnosis of nutrition. So they did blood work and assessments on the patient, but they also observed the physicians doing their own assessments. And these were experienced oncologists. So they're not nutritionists, but they have been trained in school how to do a nutritional assessment. And the results were actually very shocking that malnutrition was diagnosed in 52% of the patients, and the physicians misdiagnosed 43% of those people. So another 65% of that 43%, they were severely malnourished and they received no nutritional support during chemo. And only 11% of that 43% received only IV supplements. So it's unfortunate. So it kind of relates to my PICO because there's so much high levels of underestimated malnutrition in the patients. So people are not getting what they need to be able to get through this really harsh therapy. And my third article, it is trying to clarify the relationship between nutrition status and before chemo and how its therapeutic effect. So I looked at 43 people, and that's a very small number, but they did compare it with other studies and it matched up pretty well. They used BMI, their weight, serum albumin, which is measuring like what's your protein intake. And they used their own nutritional index and then a Glasgow prognostic score, which I had to actually look up what it was because it sounds exactly like another GPS we use, but it just essentially predicts how they're going to do their prognosis for their cancer. But the results showed that there was lower levels of nutritional factors in patients that had their cancer reoccur. So essentially what that was is that the people that had worse nutrition were more likely to have their cancer come back. So they had lower serum albumin levels, their tumor marker levels were still high, and they had worse prognosis. So that just solidifies that there's a relationship between nutrition and the recurrence of cancer, as well as just doing better. And there's a need for better measurements of malnutrition. Oh, and then another cool fact of that last article, a lot of these patients have to have surgery during chemo at one point, and malnutrition before they got their surgeries showed they had more postoperative complications, their tumor progressed, and poor clinical outcomes. So not only just for chemo, but for any operations, nutrition is important. And this fourth article is a meta-analysis. They use 1,500 articles and they search them using the keywords cancer, nutrition, malnutrition, stuff like that, that relates to my article. And they wanted to see what the current trends and what gaps and where the research is heading. And it's actually heading in a good direction because the results showed an upward trend of the topic of malnutrition related to cancer since 2019. But every one of these articles always says there's a need for more research, look at it more. Some limitations, they couldn't include specific narrow topics, so there's probably way more articles that are looking into this subject, but they couldn't do very small, like it didn't have that one word, honestly, in the title, it didn't pull up. So anything narrowed in this field wouldn't show up, and they had to cut out a lot of articles that were affiliated with Europe just because they wanted to do the US, but Europe has a lot of use of complementary and alternative medicine, which would be useful for chemo. And my last article is an experimental article, which was very cool. And so they had 90 patients that they split up 45 and 45. And the experiment group got a multidisciplinary nutritional support mode, which was made up of doctors and nurses and nutritionists, all from different departments and everything. And they would go and do all of their assessments on their patients, and they would provide ongoing support through chemo, and versus the control group that just got the conventional support that we see in the hospital now. And so the results showed that the serum tumor marker levels were lower, immune function was better, and there was better indicators in the experimental group. So that this essentially was showing the difference. When there's better assessments, the patients tend to do better. And yeah, those doctors and nurses really made an individualized plan, which everyone is different. Everybody has different cultures and everything. So they were able to zone in on what they could do for that specific patient. So my nursing intervention would be to obviously have more evidence-based research and always continuing research on the topic, but we need better and new nursing assessments. And this could include labs, food diaries, collaborating with more departments, kind of like in the MDT mode in the last article, and just going into our patient's room and, kind of finding barriers to nutrition, whether that could be like they have issues swallowing, so maybe we need to go to some different kind of nutrition. Is there a culture preference? If we're giving them certain types of food and they can't eat that food, that's not helpful to them. How is their mobility? There's so many times where people don't think that some people that have had stroke or have issues with moving their arms and stuff and can't eat correctly, they might need some help there. Or smell and taste aversions are very common with chemotherapy patients. My dad, for example, had cancer and he could not stand the smell of frying food, and he couldn't taste a lot of the things that we would eat. So the only foods that he could actually taste and enjoy was pickles, strawberry yogurt, and grapefruit. So obviously those are all the food groups. So just getting supplements where we can, providing insures, different food options to help really push that nutrition in for our patients. And these are my references. Does anybody have any questions? Oh, thank you.
Oh, you did tell me that. Maybe we did talk about that.
He's okay now, but, yeah, my dad lost like 50, 60 pounds. And I'm like, so. So actually this year, I think the 10-year anniversary.
Yeah, from football.
Go outside and get out.
Same thing that you had one. Are you doing? Huh? I'll take that video. No, you can. Yeah. Take it off. Like, how did you know? I'm blind. I'm back. Girl, got a flop. Hey, you cannot, yes, let's get it.
Yeah, take your, certificate.
Yeah, buddy.
Hi, friend. Bye, Julie. Let me just say, I'm so glad that it's not like last year. I know you weren't here last year. But there was like 50 people in each room, like packed, because the juniors, we had to come watch and like 4 seniors present. And there was way more people that like we didn't know last year. There was like 50 people in each room, like a floor. I'm so thrilled. Like, if they can do it like this, a picture with y'all. Like, we talk to each other every day anyway.
I want a picture with my presentation.
Like, I feel
Oh.
so great.
Oh, my boyfriend's on. I wonder if he missed it.
Ray, he can still hear us. I can pause it. Do I just hit it?
Yeah, click on the green arrow, the right side. That, and then hit the pause button.
Yes.
Actually-
I know. I got up in and I was like, oh God, jump scare.
Fix this.
I'm assuming that's.
I've seen it happen. I know. Multiple times. Yep. What? Oh, we're talking. That's not good.
Executing.
I
ain't doing nothing.
Anika's presentation violates security.
Do I push okay or cancel?
Y'all didn't start the recording, did you?
I can unstop it.
Yeah,
Oh.
Oh.
Where is the mouse? Okay, there we go.
I gotta be careful.
Let-
It's like a skating thing. Oh, we have- It'll blend in between the layers. No,
It went out again.
It's literally just had words.
Still recording now.
No, okay.
Share, okay. Share.
And then.
I think we're good. Yeah, we're good now. Thank you.
Good afternoon, everybody. My name is Anika Wise. I am a senior for Piedmont Nursing Program. I did my project on why is race even an issue on the maternal mortality crisis in the United States. Maternal death is the passing of an expected mother during her pregnancy or within 42 days of her delivery. Common causes are cardiovascular infection or sepsis, hemorrhage, thrombolytic, pulmonary or embolism, and hypertensive complication. As we know right now, this subject has come very big in today's society of maternal mortality, because the United States, we'll talk more about it, is one of the highest numbers when it comes to maternal mortality. This right here was a video that I was going to show, but unfortunately I cannot show it. But it's basically talking about, it's on Hulu. There is a documentary out right now that's talking about the maternal mortality for African-American women and how their numbers for African-American women are highly increased. Which just leads to my PICO question, which was, does race have an impact of maternal mortality rate in the United States? Which we'll get more in depth to. Why I chose this subject, because it's very dear to me. As everybody knows, I am an African-American woman, and I have African-American sisters and aunts. And I noticed that is a big subject. Also, I'm very passionate about maternal health. So this subject has been very heavy on my heart, because the numbers are crazy when it comes to African-American women compared to their white counterparts. As you can see, I put these two pictures up here because when you put in Google, this is how bad this is. If you put maternal health in Google, these are the pictures you get. I see more when it comes to African-American women like this, and this is the pictures you get when you see their white counterpart. So I thought that was very interesting. And this is just a graph up here that shows different numbers of maternal mortality in the United States. And as you can see, how much non-Hispanic Black women numbers are. As you can say, United States ensues among the developed countries with the highest pregnancy-related mortality rate, which is crazy for us to be one of the most developed countries, with a lot of things that we can do to prevent these things from happening. And statistics show that 700 individuals succumb to pregnancy-related complications annually. And about 4 times as many Black women as white women die from maternal problems each year, regardless of their socioeconomic status. I used 5 different articles to help me support my PICO question. And one of those was racial and ethical disparities in maternal mortality in the United States using enhanced vital records. Enhanced vital records is a fancy way to basically say like death certificates or birth certificates. It was used to understand, they used this vital record, the vital record from the years 2016 to 2017. And basically they used this to just understand the racial and ethical disparities in US maternal mortality. It was also known that it wasn't until 1933 from most of the countries start to use the actual death certificate to actual document maternal mortality. And it also was shown that maternal mortality rate for women of color was 1.8 times higher than of their white counterpart. And it also documented that preeclampsia, eclampsia, obstetric embolism, postpartum cardiopathy, and other critical cases were some of the big cases of why most of African-American women died. And also preeclampsia was the highest pregnancy-related factor contributing to maternal deaths among Black women. And all these can be avoided. 60% of all these fatalities can be eliminated. So that's an even more concerning factor. My second article was trends and social inequities in maternal mortality in the United States. This paper basically focused on a study that used, again, the National Vital Statistics, used the census, and it used like ratios and a log linear regression model to basically showcase the trends that could possibly impact maternal mortality due to race and socioeconomic statuses, maternal statuses, urbanization levels, and marital status, and immigrant status as well, and some cause of death. But one thing that was very interesting to me with this paper was that even though it did showcase that still there is an increased percentage of African-American women still dying, but it also showed that even with all those factors contributing to these deaths from these can contribute to these deaths. It didn't really showcase how, even if you was an African-American woman and all of those things were, you were married and your socioeconomic status was high and you did have higher degrees, you still had a higher percentage chance to die in maternal mortality, even from a woman, a white woman going in there with no degrees. She was a single mom. It was a still difference between that level. So that was very interesting to me. My next article is going to be maternal mortality in the United States, the pervasive effects of racism. This basically was showcased systemic racism and how it is not only in our healthcare system, it's also in insurance, education, housing. It also showed that Blacks are often more predisposed to reside in areas with low education and low healthcare practices than whites. It also said that basically, in order to fix this problem with systemic racism that definitely affect the healthcare system, we're gonna have to work on the regional and federal levels. So this is not gonna be something that we can really work on inside our community. We're gonna have to take it higher because that's the only way we're gonna break down these barriers. And my next article was A Mother's Cry, a race to eliminate the influence of racial disparities on maternal morbidity and mortality rates among Black women in America. This was a research paper basically focused on racial and ethical disparities in maternal care minorities, recognizing the factors that underlie disparities in pregnancy-related deaths, and also implemented factors to contribute to resolving these disparities. This basically showcased once again that about how African-American women are dying more in maternal mortality. But it also gave us some things that we can look at to improve it, which is like reducing racial and ethical inequities, eliminate implicit biases, also high quality preconception, maternal and postpartum healthcare, and adequate healthcare facilities in minority areas, because most of these low income areas do not have a whole lot of doctors in these areas. And so a lot of these patients aren't able to get to their doctor's appointment because they don't have the funds to get there. They don't have the transportation to get there. And so those are some things that we can look at to try to improve it. Last but not least, I had addressing racial disparities in pregnancy-related deaths and the analysis of maternal mortality related in federal legislation. This subject has become so big due to the fact of these numbers are crazy of African-American women dying. They have gotten to legislations, and the CDC has decided to look at some policies, and they start looking at policies within the areas of 2017 through December 2021, and look at some of the things that they were looking at in the White House. And a lot of these policies that was built to try to like combat this issue was either just ignored or they just basically just put them in a back burner. Like it wasn't even that important, but because this is a big issue, we really do need to start to push for these policies to be put in place, because we all should really think about each other as equals. And with that, we can all help each other out to eliminate our African-American sisters from passing away. Let's discuss. United States have a major problem in maternal health, as we can see, and women's health need to be improved before, during, and beyond maternity. And how can we fix this? I looked at something that was very interesting to me. I went to look at diversity in healthcare, and in America, the Associated American Medical College in 2021, when they did a diversified to see like some statistics, it was reported that 63.9 were white, 20.6 were Asian, 6.9 was Hispanic, and 5.7 was African-American physicians. And then when I looked at nursing, from a 2020 survey from the American Association of College of Nursing, 80.6 was white, 7.2 was Asian, 5.6 was Hispanic, and 6.7 was African American. And as we can see, that's a big gap when it comes to diversity in the healthcare system. And that's something that we really need to combat, because everybody know how comfortable it is to see other people that looks like you in whatever facility you are at. It just makes you more comfortable. It makes you more like, okay, they can understand, or they may be able to relate more to what's going on with me. And when you go into a facility, in a healthcare facility, and you do not see yourself in there, it does make you more like apprehensive to even combat or tell what's going on with you, because you might feel like this person might not understand what I'm going through because they don't have some of the situation I have. And so I think that's something that we need to combat. I think that's a big issue in healthcare right now that we definitely need to combat. I also looked at education enhancement. One thing I do know is cultural diversity training. I don't know how many of y'all do work in the healthcare, but I do. And I noticed that when we do culture diversity training, it's typically in modules that you get on the computer. You go through the PowerPoint, you answer little questions at the end, and that's it. That's all diversity is trained inside most hospitals. And to me, I feel like that is an issue because a lot of people don't take them serious because they really trying to rush. They're too busy. They don't have time to really read the information, get the information. And so I think that's a big issue. I think that we really need to combat that as having real, true sit downs and talks about diversity and culture. The way we learn in America is off of each other. Right? We learn by each other through each other. So if we having these real sit downs, these real conversations about different biases that we might even not notice that we were doing, or even about like what's different, what's going on, what's been new to representation of different cultures, maybe we could be able to really improve our patient care when it comes to different ethnicities. And then last but not least is patient teaching. When it comes to maternal mortality, a lot of women mostly die at postpartum stage. So that means that somewhere is a gap where we're not getting information out or is not given back to us. So I noticed that when I was in my clinicals, I was on the heart failure floor. And on the heart failure floor, they had these booklets and that they gave to their heart failure patients who were new or who even had it for a long period of time. And these booklets were very simple. It was very easy to understand. And these books, I felt like was very great education for these patients that they could take home. It gave signs and symptoms. It gave them different foods they could eat. It was just very interesting how easy this book was to understand. I think that maybe we can kind of implement that in maternal health when we send these moms home, so they can be able to read these simple, easy instructions, because not everybody learns the same. And at that time, after you have your baby, you're excited, your hormones are up, you're not really thinking about like, oh, when I get home, I need to make sure this and this and this and this. And also new education come out all the time. So I think that that was maybe a good idea to introduce into maternal mortality. And then my reference. Thank y'all. Huh? Oh, thank you, Grace. Is yours? Yes, thank you.
All right, so good afternoon, everyone. Welcome to Piedmont Symposium. My name is Katie Huff. I'm a senior year nursing student, graduating in 23 days. Thank goodness. Yeah. Woo. I know everybody's counting down. So I'm here, yeah. So I'm here to present my research presentation titled Day Shift versus Night Shift Influence on Cortisol Levels in Nurses. So how many people in here do shift work, whether it's nursing or any other kind of shift? Who's night shift?
Used to.
Yep, good bit of people. All right, so to start off my presentation, I would like to share a quote that I found during my research. It says, due to increasing demand over the past few years, the prevalence of alternative shift work has increased rapidly to 28.7%, accounting for 36.4% among healthcare practitioners. So we can see that's a good chunk of people who are doing shift work in the healthcare industry. And as all of you said, all of y'all are familiar with shift work, and there are various physical and mental health defects that come along with shift work. Do any of y'all feel like you have been personally impacted, whether it be physical or mental health, from working like night shift?
Yeah.
Yeah. Yeah. So one of like the big health defects that I found to be a thing with shift work is cortisol levels. How many of you know what cortisol is? Cortisol, yeah, the stress hormone. So it's like our fight or flight response. So research has been done to identify one of these major health problems as cortisol levels in nurses who do shift work. So for my PICO question, I did, do day shift versus night shift schedules influence cortisol levels in nurses? So you can see what PICO stands for: population, intervention, comparison, and outcome. So my population was nurses, obviously. Intervention and comparison kind of go hand in hand for mine. We're looking at day shift and night shift, pretty black and white. And then outcome is influence of cortisol levels on nurses. So why is this question even important and relevant? Why did I choose this? If you know me, you know I'm a stressor, and I'm sure all of us know what stress is with being in nursing school. And I've had some other health issues going on, and I've had even tests done to see like what my cortisol level was, see if that was having an effect on my physical health personally. And employers, especially in the healthcare industry, will be able to use all of this research to hopefully create a balance of scheduling and help people like, I know Anika has kids, and your kids need you to be present and healthy at home so that, you can provide for them, and our patients need us to be healthy as well. So that's why this is so important. This is article 1 of 5 of my research. It's titled Association Between Shift Work and Health. And this was a meta-analysis of level 1 study, which is very credible, one of the most credible levels of research that you can find. The purpose of this article was to explore the effects that shift work has on specifically physical health, and more specific than that, chronic conditions. So chronic meaning conditions that cannot be cured from day to day. So not like the flu. This is things like diabetes that people live with their whole life. There were several studies included in this article, studies on cancer, gastrointestinal illnesses, cardiac illnesses, sleep patterns, but I mainly focused on 5 meta-analysis that were studies on cortisol levels. And these studies, the purpose of these studies was to examine how cortisol affects physical health. The studies concluded that cortisol secretion was higher in shift workers who slept during the day. So therefore night shift sleeps during the day, works at night. So their cortisol levels were higher than people who work day shift. And it didn't really specify like a specific percentage or anything, because this was a meta-analysis and it was such a big study. It included several different small studies, but every single study that it included stated that the cortisol levels were higher in night shift. And so why is this important? Because night shift is at higher risk for many of these chronic illnesses. Like during the night shift, there's not as many resources. So people may be more stressed during the night. Nurses don't want to call the physician and say, hey, like I have this patient, and then it not really be an issue, and you wake the doctor up, and that can be very stressful. So night shift is often more stressful than day shift, which elevates cortisol levels, and in turn cortisol is a hormone, so it's kind of systemic throughout the whole body, and one thing leads to another, and it can have just various physical effects on the body. So that's why this article is relevant to my PICO. This is Article 2, titled Stress and Salivary Cortisol in Emergency Medical Dispatchers. It was a randomized shift control. It was a level 2 study, so still very credible. It was published in 2017. It was a study that took place in France at Mercy Regional Hospital. It looked at 22 dispatchers, so a small limitation to the study. It's a smaller sample size, and it was over a shorter time frame. But however, one big strength of this study that I thought was interesting was they looked at dispatchers during 3 different shifts. So incoming emergency calls, like when they answer incoming emergency calls of people, and then dispatch. So they're dispatching out, whether it be fire, police, ambulance, whatever, and then reassessment or reevaluation. So it was a completely random as to which shift you got assigned to. So that's also another strength. And then the results of the study, it showed that 22.8% of dispatchers had increased cortisol levels in the incoming emergency calls. So in contrast, cortisol levels were decreased in the lower stress, like the reassessment phase. So not when you're getting that incoming emergency call. And why is this relevant to nursing, even though they're dispatchers? Well, dispatchers work in the medical field just as us nurses do. I'm sure all of you, Taryn, who are nurses, you've experienced some kind of emergency in nursing. And we know in emergencies, our fight or flight kicks in, our adrenaline gets to go in, and that's when our cortisol levels kick in. And so we experience those emergency situations as well. And so this study can also be applied to nursing. And also, like I said, during night shift, when you don't have as many resources and you have an emergency, especially. So I thought that this study applied, even though it wasn't specifically for nurses. Article 3 is titled Cortisol Awakening Response and Stress in Female Nurses on Monthly Shift Rotations. It was a longitudinal, a level 6 study published in 2022, so a newer study, which is a strength. The purpose of this study was to examine how stress levels and the cortisol awakening response work for different shifts. So cortisol awakening response, that is referring to your cortisol levels within the first hour of you waking up. So of course that varies for day shift and night shift, that time frame varies. It looked at 41 female nurses at a teaching hospital in Taiwan. One of the strengths was to eliminate like the influence of shift change. They waited 14 days after shift change to complete the study, so that hopefully the body system cortisol levels had time to like stabilize before they completed the study. And the results were that the cortisol awakening values for night shift were lower at 30 minutes after waking up rather than immediately after waking up. And of course, like the cortisol awakening responses are pretty much opposite for day shift and night shift because their sleep schedules are opposite. And so with night shift, a lot of the time nurses, when you're not on shift, you try to live a normal life and say, I'm going to stay awake during the day, especially if you have kids, you want to be a part of your kids' lives, and then try and sleep during the night. Well, then when they go back on shift, they kind of have to switch their sleep schedule again. So that just creates, like I said, a systemic imbalance within the body, physical and mental health and sleep schedules. And so that's why this is so important, especially because prolonged stress, cortisol is secreted by your adrenal glands. And with that prolonged stress, it does damage to your adrenal glands. And in turn just creates a systemic response through the whole body. This is Article 4, titled Differences in Cortisol Profiles and Circadian Adjustment Time between Nurses Working Night Shifts and Regular Day Shifts. It was also a level 6 study, a prospective longitudinal study. In 2015, the purpose of this study was to look at the circadian salivary cortisol profiles. So basically just a saliva sample to see what the cortisol levels were and the time it takes for these cortisol levels to return to normal after work. It looked at 63 female nurses. They must work full time. and it alternated between day and night shift, and people who were pregnant or had chronic illnesses could not be included in the study. So that, you know, you could look at it one way and it could be a limit, but also a strength. Group assignments for day and night were randomized, so that eliminated any bias in the study. So I look at that as a strength of the study. With the cortisol, like the salivary, with the samples, the participants in the study collected their own saliva samples. So that could kind of be a limit of the study because you get some inconsistency with the saliva samples. As for the results of this study, it showed that night shift nurses got much less sleep, obviously. And then during the work days, day and night shift exhibited significant differences in their cortisol levels. And it also showed that night shift needs 4 days off work for their cortisol levels and their like circadian rhythm to return to normal, what it was before they were working night shift. So 4 days to recover. If you've worked shift work, you know, a lot of times you usually don't get 4 days off, especially now with COVID and short staff and call shifts. So a lot of the times it's just like a back and forth thing and your body doesn't have time to stabilize. And so that's how it's relevant to my PICO question, especially for night shift with the trying to alternate the schedules. Article 5 was titled Effects of Night Work on Sleep, Cortisol, and Mood of Female Nurses, Their Husbands, and Children. I thought this article was interesting and a good addition to my research because it includes their family. And I feel like in the medical field, you know, it's not just us being affected, it's our families as well. Because right now I don't have kids or the husband, and I live at home with my parents still, and you know, I can just kind of go and do my own thing. But you know, when you have kids and a family, you worry about working nights and not being present in their lives and just back and forth. When you get home, you don't want to wake them up, and then you have to worry about who's going to take them to school, who's going to pick them up. So I feel like this was really relevant. It was published in 2013. It was a level 6 study, and it looked at female nurses ages 30 to 45 who worked at least basically 30 hours a week. And the results of the study found that the final shift for their week was when the nurses got the least amount of sleep. And I would say that that's due to possibly, you know, worrying about what they need to do on their days off, or if they're going to wake their kids up when they get home, or you know, that's just their last shift for the week. So they probably have a list of things they need to do and higher stress during that time frame. And it also showed during periods of night work, the early morning cortisol levels for nurses was much lower than the early morning cortisol levels for other times. So night shifts, early morning cortisol levels were much lower than the early morning cortisol levels for other times. And I think that, you know, this study can be used to help guide nurses and their families to healthier work schedules and home routines. And the mother of the family needs to be present and healthy to provide for their kids. And so a strength of this study would be that they did interviews with the family, their husbands and children's, to just see their opinions on how it affects the family as a whole. So this is just kind of overview of all of my findings. All 5 articles yielded similar results that showed negative effects of shift work, especially for night shift on cortisol levels, and in turn, the physical, mental, and social health of nurses. Physical because of these chronic conditions, mental because just the fatigue and the tired and all of these extra things to worry about. Social health because you're not getting interaction with a lot of people, because most people, you know, have normal schedules where they work during the day. And because cortisol levels directly regulate and respond to like your stress in your body, we see a decline and a systemic decline in health overall because of these imbalance in cortisol levels. So once again, this can lead to a risk for chronic illnesses, irregular sleep, poor productivity in our personal lives, and a decrease in performance as a nurse due to fatigue. And I'm going to be an oncology nurse, and especially for my patients, our patients need us to be healthy as we can be so that we can provide for them. So it's critical that we as nurses take care of ourselves as well. So to conclude, the answer to my PICO question is yes, there's a significant negative impact on night shift nurses' cortisol levels versus day shift, as well as their stress levels and just their overall health status. And so we need to find solutions to these issues that's occurring with shift work and health. And like I said, this can start with creating a more balanced work schedule. Where do we start with that? It's kind of a tricky question to answer because like I said, with COVID right now, there is a lot of understaffing in hospitals. But like I said, it is crucial that nurses are healthy so that we can take care of our patients. And these are my references. Whoop, wrong way. These are my references. Any questions?
We'll take questions at the end once everybody finishes.
Oh, okay. Thank you. I'm coming to see you. Thanks. Oh, no.
I know. I have things, but I'm not. Okay.
Can I go ahead? Okay, so my name is Marilyn Rodriguez, and my PICO question was, does bias in healthcare influence the healthcare outcomes of Latino patients? So why is this a problem in the background? The Latino patient population is the largest and the most rapidly growing ethnic group in the United States. Unfortunately, people of color in the United States face multiple disparities when it comes to their access to healthcare, quality of care received, and health outcomes. Racial and ethnic health disparities persist in healthcare, with longstanding concerns that cognition bias also plays a role in the problem. Bias can potentially lead to patient receiving poor treatment, receiving inaccurate diagnosis, or experiencing delays in diagnosis. So article number 1 was a descriptive correlation design. This study talked about the way Latino nurses experience bias in their workplace. The results of this study showed that 73.6, meaning 88 nurses reported experience bias, with 26.1, which means 23 nurses perceived bias against them at least 3 times a week. That's just 1 week. If Latino nurses continue to experience bias in their working environment, they're more likely to leave that working environment, which decreases decreasing patient outcomes due to the lack of diversity on the floors. So, article number 2. So this article was a systemic review. It talked about how general, implicit, racial, and ethnic bias among healthcare providers have an influence on healthcare outcomes. This study found that people of color face more barriers to obtaining preventive care, acute treatment, and chronic disease management services compared to those that are white. People of color are also generally less satisfied with their interactions with healthcare providers. Article number 3. Article number 3 was a cross-sectional study. This study provided information about implicit and explicit bias and how it affects the Latino patients evaluated. In the full sample, approximately 2/3 of the clinicians had implicit bias against people of color. 43 showed moderate to strong, and Latinos 51% moderate to strong, while reporting very little bias against any other group. Article number 4 was the correlational research design. The results of the study showed that the Latino patients received the same treatment intensification and had similar hypertension control, but lower medication adherence than white patients. According to this article, variation in hypertension control and medication adherence treatment intensification was not associated with clinician implicit bias in people of color and Latino patients. However, this study did mention that in order to build trust and partnership, it is necessary to identify healthcare contexts in which bias does not influence outcomes. Article number 5 was a qualitative meta-synthesis research. In this research, it was found that physicians' clinical decision-making process is influenced by patients' race and ethnicity. It has been proven that Hispanic physician groups have the most diverse interactions with patients, resulting in better patient outcomes. This is just specifically to Hispanic, but mainly minority physicians tend to have more compassion towards their patients and want to know more about the patient. Also, there was a scenario in this research that I was not able to put in here, but there was a scenario that had 2 patients. The only difference was that one patient was colored and the other patient was white. Both patients presented the same symptoms of chest pains. However, the white patient was the one that received immediate medications, immediate care, while the patient of colored was like more ignored. They weren't offered the same care as the white patient. My conclusion and my recommendation. So as proven in the studies, bias does exist in healthcare, and it affects the health outcomes of not only the Latino population, but other minorities as well. Implicit bias is the most common bias seen in the healthcare settings, according to the studies. 3 out of the 5 research articles that I saw reported that implicit bias against those people of color, Latinos, and dark-skinned individuals are presented among many healthcare providers, and it affects the way people of color are treated. Therefore, it is essential that healthcare invest in diversity and cultural awareness training to address biases. Organization leaders should look forward to pursuing a mission for health equity. In order to achieve a healthier America for everyone, we must confront the systems and policies that we have produced generational inequalities leading to racial and ethnic disparities in health. And these are my references. Thank you. I have to pee pretty bad.
I'm just gonna try and run through it. Can I? Oh my God.
Angel, thank you. Be right back.
Yeah.
like listening, I don't. I know it's a good skill to have. I'm so loud.
This. Hi, everyone. My name is Summer. And I'm asking, are women valued less, specifically in regards to the nursing profession? I'd like to open with a riddle, if you've ever heard it. Just keep it to yourself, you know the answer. So there's a cop walking down the street, and he's like doing his thing, he's walking, and there's a corner. And before he turns the corner, he hears, "No, John, don't shoot me." Bang, bang, bang. Turns the corner. He sees a doctor, a lawyer, and a milkman. He immediately arrests the milkman. So if you know the answer, just take a second and not answer. If you don't know the answer, why did he immediately arrest the milkman? Any guesses? It's a good guess. It's not the right answer. It's not because he's black. But that's also a good guess. Not the right answer either.
Holding the gun.
Actually, that's a detail that I forgot to, thank you.
Wow.
There are no guns on the scene. He's not like covered in blood or anything. So, yeah, that's a detail that I left out because I'm nervous. Okay, so he arrests the milkman because the doctor and the lawyer are women, and he heard, "No, John, don't shoot me." But nobody assumes that a lawyer or a doctor of these higher professions are women. Most people assume that they're men, and the milkman is a man, ostensibly. So that's just like a little riddle that kind of plays with gender bias and who we think are eligible for these higher tiered, higher level medicine jobs. Also, show of hands, how many of you think that there might be a little bit too much of a disparity between the pay structure of physicians and nurses? I'm not saying that nurses should be paid as much as doctors. They have a lot more education and there's a lot more risk for them. But what I'm asking and what I'm asking you all to consider is that the disparity between those two wages might be a little bit high considering the job that we're all being trained to do and the profession that we're all pursuing. So I just want you to keep that in mind as we go through this, but basically, wait. Oh God. Okay, let's go back. Let's go back to the beginning. All right, so women represent 75% of the world's healthcare workforce and specifically 90% of the field of registered nursing. So that leaves 10% of men in nursing. Now, on the flip side, women represent 9 to 16% of engineers and 21% of computer programmers. Who gets paid more? The engineer or the registered nurse? Yeah, okay.
That's fair. But the rates of men who pursue nursing are rising, and there are implications for that. And I'm asking, is there, the PICO question that I'm asking is there a correlation between rates of compensation and more men pursuing nursing? So, whoa, okay, here we go. Is there a way to pause this or just let it go? Okay. So the first article that I took information from was called Worthless: Why Men and Women Devalue Care-Oriented Careers. So I want to define a couple things. I want to define STEM, which is science, technology, engineering, and mathematics. And I want to define HEED, which is healthcare, early education, and domestic roles. So the first article that I used compiled data from a bunch of studies that interviewed hundreds of university students. And they found that all of these university students placed higher value on careers in STEM versus careers in health, education, and domestic roles. And that just kind of sets the groundwork for how we think of the profession, how we value it, and its inherent value to our society. And I think it's interesting that 90% of the role of nursing is filled 90% by women, and we also culturally devalue that profession. So those are two key components to what I'm going to get into. But so basically, this is the finding, which is that these careers are significantly devalued by men, more so than women, but they are also devalued by women. And then this kind of goes back to what we were talking about with distinct gender divisions, medicine and dentistry being dominated by men, caregiving or support roles, nursing being dominated by women. Nursing is changing, gender stereotypes, kind of, sort of. But caregiving work, often performed by women, remains under-supported and undervalued in current day health settings. So I'm not saying that one is more valuable than the other, but people tend to believe that it is. And that's something to consider when looking at wages, specifically rates of compensation. So if careers in nursing are undervalued by men globally, what does this impact? And I think it does impact wages. So I went to Google and I was like, what can I find about nursing wages? And basically, my second article, titled Feminization of Healthcare Workforce and Wage Conditions of Health Professions, an Exploratory Analysis, lots of words, aggregated information from this Dutch website called Wage Indicator. And they looked at wages across 25 countries that are in lower middle to upper middle income. So very similar to the US. In fact, the US was one of those countries, but also looked at countries in Europe and India and some other parts. They globally compiled wages, and they found that they did this from 2006 to 2014. Women in healthcare wages tend to decrease as more women join the profession and increase when more men join the profession. Interesting, yes. And I think that that's just, without getting too heady, I think that there's a lot of dialogue happening about what gender means and how it is not just a biological point of reference, but a socially constructed idea. And I'm not going to get too far into that, but I do want everyone to consider the idea that men pursuing nursing could potentially legitimize the career and increase our wages, because if you have 1/2 of the population devaluing this career, it goes to show and stands to show that our wages stay stagnant. And if more men pursued this career, as indicated from this study, our wages are increased. And I think maybe that disparity between provider and nurse can be more satisfied and meet somewhere in the middle. So it also has a lot to do with upward mobility, autonomy, and viability of the career as well. So increasing equity. So another article that I pulled is, does nursing influence feelings of gender role conflict in a cohort of nursing degree male students? A lot of words. But basically what this study tried to measure was personal discrimination felt with male nursing students. So I'm not going to single you out, James, but what they found basically is that out of 22 BSN students who were male, they generally felt safe and comfortable and not discriminated against for the most part within their nursing cohort, which this is a very small sample size, right? This is an obvious limitation to a study like this, but it's encouraging, right? And the idea is that the more encouraged men are to pursue nursing, the higher potential legitimacy and wage, our wages can increase. So that's something to consider. And then also the fourth article that I'm using for this presentation is a qualitative systematic review of lived experiences of men in nursing. And so we find is that themes of value, gender, acceptance, and coping strategies were all studied amongst men who are male nurses, who live and work in the profession. And overall, men feel content with their job, and they feel a sense of provision, security, flexibility, all of those things that we're always looking for. And so basically, in conclusion, I think, first of all, nursing is viewed as women's work, but nursing careers should be encouraged at a school age level. I think we should start talking to young boys and encouraging them to, pursue this as a viable career path. Young boys want to be doctors, but maybe they also want to be caregivers too. And it's important to not have such a strong gender stratification of the profession. And I think historical cultural biases affects the rate of compensation. I think companies need to have better compensation transparency. I think that, men making up 10% of nurses worldwide, and that's increasing, that can mean that more healthcare employees actively attempt to shatter these socially constructed gender norms that we've been kind of holding on to with a death grip. And I do want to point out one quick thing, that there is a glass elevator for men in nursing. Men typically do get promoted faster, and they tend to excel in nursing. So this is something that is also supported by my Article 2 study. And I think it's important to note and important to consider when disseminating information about men who pursue nursing. And it could be used as a way to encourage men to get in there and help things out for all of us and make it a more equitable place. So anyway, I think mostly just advocacy for legitimization of the nursing career, regardless of its core population, is important. But if it is more representative of how the world is, it's like what we have been discussing. If more of a representative whole represents this profession, more equity and better care can be given across the board. The end. Thank you for letting me go pee. That really helped me a lot.
Okay, that was really good. That was real good.
Really?
So we can have a question in the car. Yeah. I don't have any questions. I'll come stand with you somewhere. I mean, I'm sitting. Well, I'll sit in your lap somewhere. What made you choose that topic, Summer?
I've been curious about for a while. I mean, having gender issues have always fascinated me, and that's probably not surprising, but I chose the topic because I felt intuitively that there's a reason why male dominated careers end up having a higher compensation rate than female dominated careers. And I purposely avoided going into I purposely avoided trying to define like sexism, and I didn't really want to get in the weeds there. I just wanted to lay out the facts, which are that this is exactly what's my intuition was correct, so.
My question is for Katie. So all of us are probably gonna start on night shift. So how,
Terrifying.
I know, so how do, I don't know if you found any research on how to like cope with all those things, because we are gonna have to. Be on
No,
night
and that's one of the things that I was really surprised by, like, it did say, you know, that it's causing these chronic health conditions and irregular sleep patterns, but none of the studies really went into depth on, okay, how do we create these balance schedules? How does somebody on night shift regulate their cortisol, like, and get it to that point of stability? And I guess it's just because, you know, where do you start trying to balance schedules now in nursing? Like, what is a balance schedule in the hospital? Like, I mean, you know, like I said, with COVID, we're already so understaffed. And I feel like it's just kind of one of those things. Some people, and I've been told, either you love night shift or you hate it, like there's no in between. So I guess for some people, their bodies just adjust easier or regulate easier, but there wasn't anything specifically saying like, if we do this, it will help stabilize the cortisol levels, which is kind of unfortunate. That's one of the downsides to the topic, because I'm like, I don't know if I'm starting day shift or night shift, but I'm like already trying to mentally prepare.
Yeah.
But yeah.
I have a question. No, it's an easy question. I promise. In your article, did it say like what type of discrimination was, you know, nurses experience? Did it say like what modes, and was it by other healthcare workers or patients or both?
Most of the, but because that article was taking place, I think, in the conventional convention for nurses, for Latino nurses. So most of it took place and in the workplace. It didn't say what type of like specific bias that they received. But for them to be able to, you know, to see it. Yeah, but.
Not a question, I just have a comment. I would just like to applaud y'all for considering some of the social issues among nursing. That's can be very intimidating to stand there and present information that can make people uncomfortable. So I appreciate y'all being willing to take that on and giving us some enlightenment.
Well, thank you.
So I happened to catch the PBS documentary that you referred to, Birthing Justice.
Yeah.
And there were many things in it that were surprising to me.
Yeah.
Shocking, you know, those types of things. And I was curious if during your research, not particularly to that documentary, but during your research, was there anything that was really surprising to you?
Well, one thing that was surprising to me was when in one of my articles, I can't remember off the top of my head, but it really showed how, which I kind of brought up in the Little Simpsons, but that it really didn't matter like who you were, you know, it didn't matter what you have and the money you have and the status and any of those type of things. It didn't matter. It really was the biases off your color of your skin. I don't know if y'all know a lot of stories about Serena Williams. She almost died during her delivery because of the color of her skin. And this is somebody who's publicly known and many people love her, and she's a millionaire and she's great at tennis, and you know, she did, and her status didn't even matter when she went to have her baby.
She's very
She was
healthy person.
Yeah, healthy at that, and all it was is she was a black woman. And that to me was very touching, that, you know, going into having, I have 4 kids by myself, and thank God, you know, I haven't personally dealt with biases having kids, but at least not to my face, you know. And that a lot of my sisters are going in here and they're terrified, not knowing they're gonna come out of the situation healthy and be able to live a long life with their own babies. The story that I was gonna show was 2 women who basically passed away healthy, documented their whole pregnancy and everything. One of their moms actually worked for the hospital that she passed away in. And then the other one was a mom was like an advocate for maternal mortality in African American women. So it just showed you right there. It really doesn't matter. It's really all about biases, which I could also see as well, because you know, this is a big saying that African American women are these type of women. And there was also some locality that since GYN back in the day, that they operate on Black women, and when they operate on Black women, they did it without medicine. So that already started this biases that we can be able to control so much pain, we can handle so many things, that when we do complain about something, it just ignored. And that was one of the things in that documentary that you were talking about. A lot of those women were ignored. Like they literally went to these doctors and kept telling them over and over again, I'm having these issues, I'm having these problems. And they was like, go home and lay down. Which I saw on my sister. I might didn't do biases, but I saw my sister who had preeclampsia the first time with her baby, her second baby, thank God that, because I'm an advocate for her and I understand what's going on behind the scenes. She had issues with her third baby, where she basically was having headaches and dizziness and all the signs of preeclampsia. And the nurse told her, go home and lay down. And if you feel bad, call again. I took it upon myself and got in contact with a doctor. I'm like, I'm not comfortable with my sister laying down because I don't know what could happen in the next couple hours with these symptoms. And it pushed the envelope, and when it came to the fact that she had to go into labor the next day. So that was something serious that could have happened to my sister. And I work for this hospital. So it just shows you right there, it really doesn't matter, you know, much about your status or your economic or where you come from or what kind of education you have. All in all, it really is that we have to change this biases when it comes to African American women. And I think that's why this is a rise of maternal mortality on African American women. Sorry to go on so long. I'm very passionate about that subject, but here's some major issues that we need to work on when it comes to biases.
Yeah, and Georgia is actually
The highest. Yes, it's the highest. Our own state we live in is the highest state of maternal mortality. So that to show you how much work that the healthcare we're gonna have to put in, because we can't keep allowing this to happen. No woman should die. I'm gonna put it out there first. No woman should die of maternal mortality. No woman. Every woman should be able to have their baby, a healthy baby, and go home with their baby. But it's definitely really sad when there's this big gap between who do go home and who and live and have a fulfilled life with their child and who don't. So yeah. Sorry. Anything else?
Good job, guys.
Thank you. I'll be TikTok already.
It just doesn't come out that way. It's finally screaming. Yeah, already. I want to say. Yeah. Yeah, I'm back. Come on in.